You have a digital certificate. I have a digital certificate. I want to send you a message. I encrypt the message with your digital certificate and send it via plain SMTP, plain old email. But because I encrypted my message with your digital certificate, only you can decrypt it. Or similarly, if you want to send me a message back, you have my certificate, you encrypt the message, only I can read it. So this turns out to be a very simple technology. Existent digital certificate technology, existent email technology, and we have most of our vendors in the United States that have agreed to introduce this technology in their electronic health record products because it is easy. It doesn't require new software. It doesn't require new development. So for example, I actually have an email address at Microsoft. Microsoft has a product called Health Vault, their personal health record. And my email address at Health Vault is direct.healthvault.com. So any doctor sending medical information to that email address automatically incorporates into my personal health record. It's very simple, simple email. Now, last time I was here, I described Google has Google Health. Google has decided to shut down all of its health products out of concerns of privacy. Really the reason is Google was worried that federal regulations are so complicated that Google could get audited, and Google does not want to be audited. So, interesting, Google said we are shutting down, but Microsoft said we will happily help Google with its problems. And so Google users can use this protocol to email all their Google data to Microsoft. Now I was told Larry and Sergey, who run Google, were told by senior executives, we are going to email all Google data to Microsoft. And they got very, very confused. But Google and Microsoft were able to implement simple email addresses between the two organizations very quickly. Japan has many people concerned about privacy. The United States has many people concerned about privacy. Rather than demand a specific technology, we have implemented policy. So, for example, I cannot store patient information unencrypted on my BlackBerry. Encrypted is okay, but if I leave this on the subway, someone could read patient information. So we have simply created policy about encryption and the wise transmission of data and the mobility of data, and enforced policy. So for example, I had at Beth Israel Deaconess a privacy breach where a thumb drive, a USB drive, was compromised. It had patient data on it, and I had to report that privacy breach to the New York Times, the Boston Globe, and the local television stations. And the federal government investigated the breach. So this is just an example of more policy, more communication, and more enforcement. We have tried to educate patients about consent. And I know Dolphin, for example, has a consent. Patients can decide where data should be shared. So that's something important we were trying to do. And we are working on standards to help identify patients because we don't have a national healthcare identifier and won't have one soon. So we have a series of goals over the next several years. make sure that electronic health records and health information exchange are adopted, reduce costs, educate our patients so they expect electronic health records to be used, give patients access to all their data, and then we believe we will have achieved the right balance of payers, providers, and patients using electronic health records wisely to transform healthcare, reducing costs, and improving quality. We have tried to be innovative, providing decision support, and worked on additional care coordination. We're working a lot on the measurement of population health across the community. And you may have heard about the Obama healthcare program. The Obama healthcare program is about ensuring all U.S. citizens have insurance. Now, this is where I become very humble, because in the United States, we spend $8,000 per patient per year on healthcare, and in Japan, you spend $2,000 per patient per year.
ここで少し気持ちを落ち着かせて、少しハンブルに申し上げたいと思いますが、アメリカでは年間1人にあたり$8,000のヘルスケアのコストをかけています。かたや日本は$2,000であります。
So when I went to the diet and said, I am from America and I have some good ideas about healthcare, the diet said, you spend 4 times as much and 40 million Americans are uninsured. What do Americans have to tell Japan about healthcare? I said, well, we are spending $27 billion, so I can tell you what worked so that you can use your money even more wisely. They like that. So our future direction is to ensure federal committees work on policy and technology, and that we implement all these programs that I have outlined, because many of them are going well. That we ensure we measure our outcomes, that electronic health records are not implemented for just technology's sake, but to ensure the health of our population. That we continue our work on standards, our work on security, on ensuring every American has equal access to electronic health record data, and ensuring that the patients are educated along the way. So if those were our goals over the last 2 years, how can we translate what the United States has learned into lessons for Japan? So I want to just switch presentations, and I was just asked to write a paper by the Health Global Policy Institute, HGPI, of Japan, in collaboration with the Center for Strategic International Studies, CSIS, in Washington. CSIS is Henry Kissinger's group, one of our famous secretaries of state. So what I tried to do in writing this paper was take my experience from Japan and illustrate how some of the programs in the United States could work in Japan. I came in February to meet with several Japanese leaders and left a few days before the great earthquake in Tohoku. And so this paper turned from a general statement of policy and technology into how can we ensure that if earthquake, tsunami, nuclear issues occur in the future, that every citizen of Japan is protected with an electronic health record. I had several people from Iwate Prefecture and from Fukushima share with me photographs of how records were kept immediately after the earthquake and tsunami. And the answer is pieces of paper pinned on plywood boards. They were not using an electronic health record. And in the United States, we do have experience with large natural disasters. We had Katrina create a flood in 2005. It was very similar to the kind of damage inflicted by the tsunami. So as I've met with Japanese leaders, I've suggested that healthcare IT in Japan can take 3 phases. If there is a natural disaster, how can there be a community health record at a prefecture level to support medication lists, problem lists, and allergy lists for use in an emergency? So much of the issue in Iwate and Miyagi was people didn't know what medications they were taking. It was hard to know who had diabetes or congestive heart rate failure or COPD. So that's one phase. In Iwate, there is much destruction. New hospitals will need to be built. So what might we do in the short term to build a special economic district in Iwate and Miyagi to implement electronic health records and health information exchange as a pilot project? How might, without changing federal regulation around privacy, we experiment in Iwate and Miyagi about using new technologies for sharing healthcare data? And like Japan, the United States has an aging population. How in the long term can we use electronic health records with an aging society, telemedicine, home care monitoring, health information exchange to ensure costs can be contained as more and more consumers need advanced medical care? So if those are 3 phases, some priorities I recommend for Japan. Widespread adoption of electronic health records in hospitals and doctors' offices. A national identifier that helps us link electronic health records as patients go from place to place. Now this may not necessarily be a correct impression, but here's what I think. So in the United States, we have many different first names and last names. It is possible to use first name, last name, date of birth, zip code, and identify a person. Well, it's not perfect, but good enough to link their records. I'm told that in Japan, let's say Yoshihara or Nakamura may be a common enough name that it may be hard to use just first name, last name, date of birth to uniquely identify a person. And therefore, the notion of a national healthcare identifier could be very helpful. And the creation of a database with that identifier that is used during an emergency. And of course, there will need to be privacy policy, but I think pilots are necessary, as I mentioned in Iwate and Miyagi, before we try to change privacy policy at a national level. I think the people in the Diet that I talked to were worried that if you change policy nationally, it could have unintended consequences. It could cost a lot of money, so they would prefer a local pilot first. A security framework that allows the transmission of records from place to place. And whether that is something like Dolphin or something like the Direct project with email, something needs to be put in place to allow transmission of records. Now, my understanding is that many hospitals in Japan are not connected to the internet for fear that their clinical systems could be compromised by hackers. The internet can be secure enough. So the hope is that we can create technology that allows existent networks to be used for healthcare information exchange and not just private networks or new fiber. Japan should embrace across the country certain standards, such as the medical markup language, to ensure that systems can transmit data about patients and share data, even though they may be running different software. It seems to me that working at the prefecture level or even at the ward or city level might be easier. And that is, rather than start large, start small, and then see what works and build on what works. So how, if that is a set of priorities, do we convince government to do it? Well, as I mentioned, the Ministry of Finance is very interested in efficiency and savings. So we can take examples from the United States and other countries about benefits of healthcare IT in reducing costs. Of course, everyone cares about quality and effectiveness of care. My sense, and I always have to be careful about this, that the length of hospital stays in Japan is long. Sometimes I think an average I've heard is 12 days, 14 days. In the United States, the average hospital stay is 3 days. Again, not that the United States has everything right, but if we coordinate care across hospitals and doctors' offices and the home, might we be able to reduce hospital stays? Might we be able to reduce the number of visits to general practitioners, the number of imaging studies, not only because there's cost, but because there's radiation exposure if many CTs are done on a single patient. And I'm told, again, have to be so careful, that in Japan, that there's a rather high number of prescriptions given, and that sometimes if patients go to a doctor and don't receive 2 or 3 prescriptions, they may feel that they didn't receive good care. And don't know if that's true. But if we use electronic health records, we may be able to achieve these benefits. Now, the U.S. program has focused on many of these goals: quality, safety, efficiency, ensuring patients and families are involved in their decisions for health care, that care between hospitals and doctors is coordinated, that overall the population is monitored. Now, of course, I immediately have to apologize again. I walk the streets in Japan, everybody looks so healthy. I walk the streets in the United States, and everybody looks overweight. But we are trying, especially in parts of the United States where obesity is reaching epidemic proportions, to now measure and monitor body mass index and diet, blood pressure. And of course, we are working on security and privacy protections. So our goals, and what I perceive are the goals of Japanese policymakers, are very similar. In 2005, Katrina created a devastating disaster. And like Japan, it wasn't the initial disaster that was the problem. The storm did some damage, but it was the flood that followed when the levees broke and Lake Pontchartrain drained into New Orleans, creating a devastating flood that was the problem. It was our worst national disaster in history. And so we had an idea that in September of 2005, what if we took databases from some of our state and federal government programs, Medicare and Medicaid, some of our pharmacies that have databases, and some of our insurance companies, and created a website for just 90 days, only 90 days, that would allow any doctor in Louisiana and Mississippi to look at the medication lists and the problem lists of patients in Louisiana. So this required a change in privacy policy. See, normally we have, like you do, consent. Doctors have to demonstrate a pre-existing relationship before they look at records. Here we said the disaster is so significant that we think it is a greater good for society to have a web-based database accessible by doctors, that it will be okay for 90 days to to relax privacy policy. So I think our experience in Katrina Health could be applied to Japan because there are a number of Japanese that have national health care provision, and there are databases at a national level for some patients that will allow a similar kind of website to be created. A few thoughts on Japan and the United States. We have multiple healthcare insurers. You have multiple healthcare insurers. Our doctors and hospitals are paid for the services they deliver, as opposed to, there is Obama's plan that would not have fee for service. It would give a single payment per patient per year to the doctor to keep you well. But for now, we're both receiving payments for services delivered. We have thousands of independent hospitals and physician groups that don't coordinate care. Often our physician offices are small and not very technologically savvy. We are both concerned about privacy. We both have high variability in care. We both have inconsistent adoption of electronic health records. Kyoto may be wonderful, but as soon as we go to the western part, further west, it may not be as good. Katrina had a similar situation to Japan. We have a lot of policy experience in Japan, and I think Japan certainly has a desire to examine some of our data and be guided by some of our experiences. Because we have a lot of research that's been done on what works and what doesn't work in healthcare. So here are some of the strategies I'd recommend. That at a federal level and at a prefecture level, Japan set policy goals. Is the policy that we will have a prefecture disaster or emergency database for natural disasters? Is a policy goal that we will attempt to coordinate care so the aging population gets more consistent, higher quality care? Set policy goals. Pick technology that's good enough. The same kind of program we had in the United States to certify technology that does what you want it to do to achieve policy goals. I know the Japanese government is not going to want to spend $27 billion, but offer some incentives for doctors to change their behavior. So, this is what I'm told is true about Japan. Could be totally wrong. Young doctors love technology. Very old doctors, well, they may not care so much about change. It's the doctors that are in the middle, that are making a lot of money today, that don't quite like technology, that resist change. So, incentives are very important for the doctor who's, say, 50 years old and has a small private practice that is threatened by electronic health records and health information exchange. Pilot new models for privacy and security in Tohoku. And create education among the population that electronic health records should be a part of their care. If every child in Japan has a mobile device, why not create an expectation that your mobile device can be part of your health care? This will take many experts. So one challenge I have had with the Japanese government, and I mean the federal government, is I am not sure who makes the decision. Is it the Prime Minister? Is it the heads of the ministry? Is it a director? Is it a bureau? I'm not sure. And sometimes, and people in Japan have told me this, it's hard for the Japanese to know who makes decisions. So create a committee of experts to advise the government on policy and technology. Make those meetings open to the public so that every debate is heard by all who are interested. create electronic health record expert teams at the prefecture level so that every doctor and hospital can consult an expert in their prefecture. Establish health information exchange organizations in every prefecture so that there can be the technology to share data, build registries, create emergency databases, and of course, protect privacy with policy and technology. Now, a few thoughts. There is no need to eliminate all existent systems. It's okay to leave existing technologies in place. Dr. Yoshihara and his team have shown that you can build interfaces, that you can use HL7 or MML or other standards to communicate between existing technologies and new technologies. So that's okay. Leave existing technologies that are working in place. Focus on implementing electronic health records for those who are using paper. Encourage the use of personal health records. So this is one important idea. If some Japanese people are worried about privacy, give the patients control of their own privacy by giving them a personal health record, and they can decide where the data should be shared. And as I mentioned, a national database from existing data sources. You have a national health insurance program, and add new data sources when they become available so that a patient's medications and problems and allergies are available in a disaster. So with that, I wanted to leave plenty of time for questions. But the paper that I wrote is being translated into Japanese by HGPI and will be widely available. And of course, I plan to be back in Japan quite often because anything I can do to help Japan is something I feel is so important as my favorite country. So your questions.
Thank you very much.